We on? Okay. Welcome everybody to the October 13th staff meeting. It's Tuesday, October 13th at 9 o'clock. So we will pass the staff meeting over to our county manager.
Thanks, Chairman. Good morning, Commission. And I'll go ahead and say on the phone this morning, Commissioner Howell is remoting in, and Lindsay Poe, so our CFO, is also on the phone this morning. We have two items today. Tim Kaufman, I think he drew the card for both of them. One is an update on COMCARE operations and the kind of a fiscal overview of what's going on there. And then the second thing we'd like to talk about is just, Tim will give a brief update of just kind of a testing status, because there's a movement on that almost every day with the state and our efforts with Wichita State and some others. So he'll give a high-level overview of kind of a testing status. So with that, we'll start with COMCARE, and I think he has PowerPoint ready for that. So,
Good morning, Tim. How are you?
Good morning, Commissioners. I'm well, thank you.
Thank you, Kate.
What I'd like to do this morning is give you a brief update of how COVID-19 has impacted COMCARE operations, particularly fiscally. They are maybe the closest thing that we have in the organization to an enterprise fund. They generate revenue to pay for most of their activities, and so I'm going to kind of explain what's happened to them specifically and how it compares nationally to healthcare in general. But I'll go quick, and I'll be happy to answer any questions if you have them.
Hey, Tim, I'm sorry to interrupt, but just a definition for the public and for us all, an enterprise fund means an operation that operates almost solely in their own budget.
Correct, yeah.
On the city side, it's the airport, it's the parks, that's what happens on in the water system in the city side. So
correct. It's kind of a fee-for-service operation, and
right.
so there is some mill levy funding. There's also some grant funding from the state, but there's a lot of expectation around generating revenue through delivery of services. So
right. Thanks for letting me you clarify it further. Thank you.
Good description there. So that first slide talks about how COMCARE is funded. This is how we budget the department, and you can see that the great majority of COMCARE's budgeted revenue is tied to their delivery of services. So there's some property tax fund, about 11%. There's 2% that comes from housing and a couple of other really small grants. And then the rest of it is in what we call the COMCARE Grant Fund. And that includes both the grants that we receive from the state and then the fee-for-service revenue that they generate through the delivery of services. And so that's how the organization is funded. And then let's dive specifically into the grant fund sources and how that works out. The vast majority of that you can see is from Medicaid fees, and that is directly tied to the delivery of services. So our staff deliver a medical service, and then Medicaid as the payer source, the insurance for that person, pays COMCARE. Intergovernmental includes some of that. That's primarily state funds. There's a little bit of federal funding in there, but those are grants that come to the state and contracts that come from the state. We also collect payments from insurance companies. If anyone has regular insurance, a small amount there. There's a little bit of cash that's budgeted, and then there's a few other odds and ends that I've put into that other category, but that's a really small amount compared to the $42 million. Yes.
Question. Yeah, I'm sorry. I didn't see the light.
No, I just flipped it on. Okay. Thank you. So the insurance and other charges for service and the cash. So the same question I asked EMS last week. Are insurance companies writing things off?
Every insurance company has a different process. And so with our insurance companies, help me understand your question.
So if I go to the doctor and they charge me $100, but my insurance only allows $80, they write off the $20. So are we writing off payments? Are we charging the same thing that an insurance company would allow to a person paying cash?
Yes, but most of the folks that pay cash to us are on a sliding scale.
Okay.
So we collect much less from cash payers than we do from insurance and from Medicaid.
Perfect, thank you.
Last Thursday at the Economic Outlook Conference, there was a speaker that talked specifically about healthcare and the outlook, and I captured a couple of different slides that I want to share with you. And the impact here is really in the difference in the bar graphs. So the graph on the left shows visits per 1,000 patients in 2019 versus 2020, and if you go through there and add those two blue bars up, it's about half of what was in the green bar. So roughly half as many appointments now in 2020 as there were in 2019. That's the national perspective. Here's what's going on with our folks.
Wow.
Patients attend, many fewer patients are attending appointments, and the frequency of those appointments is down. But we continue to support individuals through non-billable activities. So we've got a lot of folks that we call and check in on and make sure that they're okay, encourage them to stay engaged with services, encourage them to come in when they're comfortable, but we're operating at about half. We've got two different categories. Some things we get paid for as an event. So if if anyone comes in to see one of our doctors for a med check, usually a short visit to renew a prescription for someone, that's an event. Hours are really tied to the rehabilitation services. So if we've got a case manager that's working with an individual in the community on education, on employment, that sort of thing, those are duration-based charges. And so we've got events and hours, but again, dramatic reduction in 2020. The reason that I show this service location data is because it tells a story about what has changed about how we deliver services. If you look, and I highlighted those last two, the phone and telehealth, so over 40% of the services this year have been delivered electronically. In 2019, about 1% were delivered that way. So,
Commissioner Cruz?
Thank you. Do you have a list of the other community locations?
those are going to be potentially the grocery store. It's going to be in an individual's home. It may be at their workplace.
Home would be home.
Okay, home would be home. It's going to be a grocery store. It may be
Is there a way
a
you
job
could get me a
search.
list of that?
Yes.
Like just, I mean, you don't have to list them
It's not
off
going to
now.
be an exhaustive list, but I can give you a list of the types of places that those are.
Thank you, Tim.
But the important point here is that we're delivering a lot of services over the phone and by video, and that's just a different way to deliver service. And one of the things that has happened because of that is the service duration goes down. Folks engage a little bit less if they're participating by video or by telephone. I would imagine that each of you has experienced Zoom fatigue at some point in time. It's kind of exhausting to sit in front of a screen for a long period of time. Our clients experience that as well. The interaction that they have with an individual is less rich if they aren't able to do it by in person.
Were we able to provide any support to those clients who didn't have access to electronic devices before this started?
We have been able to. So we've set up a room over at our crisis center so that people could come in and use our equipment to make that connection, still be distanced, but could do that with our equipment and do it telephonically. And we're in the process of acquiring some additional equipment that we're going to work to get in the hands of our consumers. Now, I will point out that our medical staff in particular do an assessment with all of their patients to determine what's the right setting for them. And so if someone is not able to get the service that they need electronically, we're going to allow them to come in. We need to limit that as much as we can to protect our staff. The medical providers that we have may have caseloads of 800 to 900 individuals. If we have one of our med providers get sick, that impacts a huge number of patients. And so that's why we're very selective. Our med staff are very selective about the folks that they're able to see in person. They continue to do that, and they continue to evaluate. but we really need to protect our med staff as well.
Does this number include the schools? The program,
All
the
of our
pilot
nu-
program that's in our schools?
Yes, all of our numbers include schools. So one of the drops, one of the things that attributes to the drop that we've seen in volume, schools closed early last year, so we didn't have as much access to kids because they were at home, and so we had to connect with them in a different way. We continue to work with those kids, but we weren't able to work with them. The whole advantage of having our staff in the schools is that there's that immediate connection, and so we've lost some of that as well. Again, from the Economic Outlook Conference, the important thing here is that this is what has happened across healthcare. So this is dental offices, physician services, hospitals. The drops are just really dramatic in terms of the amount of spending that's going on in those healthcare settings. So this is not specific to COMCARE. This is happening across the country, across all medical systems in the state of Kansas. Every CMHC, and there are 26 of them, is experiencing some kind of a drop. Urban centers are experiencing a more significant drop than rural centers are, but it's going across the system. And then this next slide shows the financial impact. And so the first couple of months, COMCARE also, this 2020 is the perfect storm in so many different ways. COMCARE implemented a new electronic medical record on January 1st, and whenever you implement a new electronic medical record, it takes time for your staff to get accustomed to that and adjusted to that. And so volumes were down a little bit in January and February because of that. As things were starting to pick back up in March and they got really good at using the new system, then COVID hit, and so things have been slow since then, and that has impacted revenues. Expenditures, we still have to have our staff. Again, our staff are delivering services. Many of them are not billable at this point, and so right now, shortfall is $3.9 million through August. But COMCARE's done everything they can to maintain viability. Personnel costs represent about 68% of total expenditures, and so that's a big fixed number that they're working with, but they have tried to manage that as well. Significant number of employees participated in the furlough program. Hours worked in May were 26% less than in March, and that has really helped from a financial standpoint because that was a significant reduction in expenditure. The department has increased their flexibility regarding leave without pay, recognizing that staff have issues with childcare and everything else, just like every other employee, and so that has impacted both revenue, but it's also impacted their expenditures. They've held a number of positions vacant as a savings tool. They've repurposed staff as vacancies have occurred rather than replaced, to the point where the employee count is below 400 for the first time in I don't know how long. It's been about, they've had over 400 employees. They've got a number of part-time employees. We've had a number of part-time employees decide that they didn't want to put themselves at risk, and the type of work, particularly in our crisis center, it's in-person interaction oftentimes, and so we've lost a number of providers, and so our employee count is down significantly. And we've also helped staff the health department and EOC as well. The earlier shortfall that I showed was a comparison 2020 to 2019. Current year in the COMCARE grant fund, there's a shortfall of $3.2 million through August. So what does this mean? Well, one of the things that I wanted to point out is that there have not been any intentional eliminations, reductions, or denials of service for anyone. Particularly in our addiction treatment services program, those services are very heavily court-driven. Not many people self-identify and choose to participate in addiction treatment services. A few do, and we continue to see those, but most of the folks that go through our addiction treatment program are court-ordered, and because the courts have been pretty much closed down for the last 6 months, there are very few referrals coming through, and so that's part of the, we've seen a significant drop, particularly with addiction treatment services, but that was because the referral service has dried up. The other thing that's very real is that patients
Tim,
react.
question, please.
Tim, yeah,
Yes.
thank you. Okay, so addiction services. So what is, and this is for later, if you could get me this info. So what's the percentage of people who come in off the street asking for addiction treatment versus court ordered? Can you get me that info later?
Yes.
And then what is the current wait time for someone who is seeking treatment through our crisis center for addiction services? If you could, can you get me that info?
I can, yes.
I wonder how has it changed since all of this started? And then again, or in addition to that, what would be the average age of a person coming? Like, give me the demo of who is coming in. It's like probably a white male, 30s, 40s-ish.
Probably still, yeah, that's
Okay.
most typical, but yeah, we'll get you that
Okay,
information.
thank you.
Our patients were just like many other patients, and we saw it on some of those national slides. Folks sheltered rather than attending appointments, and we understand why. We have seen some positive changes regarding telemedicine. Medicaid particularly was very reluctant to pay for telemedicine services. Because of COVID-19, they've loosened that up. They've allowed us to deliver, as you've seen in some of the earlier data, a lot more services that way. But those changes are only temporary, and we don't know how long they're going to last. Ideally, they would continue to pay for that type of service in that manner, but that's yet to be seen. And we expect the nature of services to continue to change. I think there are some people who've really adapted well to televideo services, that sort of thing, telemedicine, and I think we'll see an increased interest in that. And it changes the workplace for us a little bit. We know that things are going to be things are very much different now than they were 6 months ago. We expect they're going to be even more different 6 months from now.
Tim, this says use of family PC. So, I mean, is there a way, I mean, they don't have to do it on their PC. They could do it on their phone.
Right. Next slide. I'll get to that. But
Okay.
and that is one of the things that some families are having to make that choice. If you have 3 or 4 kids and you're trying to juggle remote school and then you've got an appointment too, sometimes families just run out of devices. And so we're trying to work with them in that regard. But that's a reality that many of our families face. We continue to expect an increasing demand for services. This has changed the nature of some of the calls that we receive. But the other thing that has changed is the individuals that we see and the resources that they have. We're seeing more and more individuals that don't have insurance and don't have an ability to pay. That is the reason for the Community Mental Health Center network to be in place to serve individuals without insurance and without coverage. But it also depends on, as you saw in those earlier slides, folks with a payer source to make it all work. And we've seen that mix change already. We're seeing a number of people, and it's only makes sense if people are losing their jobs because of the impact of COVID-19. Oftentimes they're going to lose their insurance as well, and that job loss may cause them to also seek services. And so now we've got an influx of folks who don't have a payer source, and so we continue to work through that as well. The other thing that's very real, and we heard it a little bit earlier this week as we talked to the hospitals, but provider fatigue is real, and our providers are also on the front lines, and they're experiencing trauma, and this will have an impact on them now and in the future. And much of the work that they do now is around grief counseling, people that are experiencing loss, whether it's family, whether it's work life, whether it's activities that they were able to enjoy doing before and they can't do now. But the nature of the work that our staff are experiencing is different now than it was in the past. And they're also experiencing loss and illness just like everyone else. One of the first deaths in the community was a coworker of many of our existing staff, and so that hits folks too, and they're not immune to this disease. They're expected to continue to come in and help folks, but the disease impacts them as well. The nationwide shortage of mental health professionals is here. I've talked to you for a number of years about how difficult it is to recruit and retain folks. Last week, Dr. Gallagher talked about pay issues and retention. He could have been talking about COMCARE staff the same way. There's really no difference in that regard. And so one of the things that's happened is there is a kind of a have and have not environment. The limited provider market creates an opportunity for individuals to go into private practice sometimes, maybe change their workload, change the expectations, and they're able to see folks that have insurance, and that again reduces the payer mix that we see in our environment as well. So there are lots of financial challenges on the horizon. So what do? COMCARE has aggressively pursued some additional funds. At times, their county status has precluded them from access, and specifically the PPP loans, the 23 of the other 26 CMHCs were able to apply for and get PPP loans for their payroll impact. That wasn't available to COMCARE as part of the county structure. KDADS has provided some funding, and they have, COMCARE received some funding, and they're going to spend that money on, primarily because of some of the rules around the money, on equipment, including devices for folks that will be connecting for telemedicine visits as well. So we're going to buy some devices, and we're going to issue them to patients and have them connect to us that way as a way to keep them and us safe. And we work closely with Lindsay and finance staff, and they're aware of the circumstances, and they're considering several different options to help address these shortfalls as they've appeared. It's a challenging time, but the staff there, I couldn't be prouder of the staff at COMCARE. They're doing tremendous work. They're working in a difficult environment and difficult times, and they're still delivering really high quality services. And so very proud of them and the work that they do. But I just wanted to let you know where things were financially in particular, because Lindsay will be talking to you in the future as we go forward, how we can maybe address some of these issues as well. Happy to answer any other questions.
Okay, Tim, obviously, thanks for the challenge to provide services, and I'm assuming that they're all trying the best they can through various means as you described. So there's a $3.2 million shortfall through
Yes.
the end of August.
Yes.
Is it so traditionally, does this all balance out financially?
Most years.
Most years.
Yeah.
Okay.
Most years we're going to be on one side or the other of the line within a couple $100,000. This
Okay.
is an unusual year, and so we've
So
got.
in the past, that couple $100,000 shortfall, is that just we absorb in the general budget?
No, COMCARE's got has had an operational reserve
Okay.
that they've
Okay.
managed over the years 4 times like this. One of the things that's unique about the payment system that they're in, even though it's a small amount, that $11 million makes a big difference. And the state fiscal year begins in January or in July, and sometimes we don't get that initial contract payment for 4 or 5 months. And so there's always been a reserve available. They have been relying on that reserve throughout this difficult time, but we're hoping for some relief as well.
So that reserve is just held, as we said at the beginning, it's its own enterprise fund. So it's not, quote, touchable from other departments.
Correct.
Okay. And then did I just see that yesterday we had a message, is something on the agenda tomorrow for $900,000 approval for a CARES? Will that help towards this $3 million?
That's that KDAD Sparks money.
Right.
And so in this particular instance, it will not, because we're part of the county system, we can't use it for lost revenue, but we
Okay.
can use it to purchase some equipment
Okay.
and that sort of thing.
Okay.
And if I can I interject just for a moment? I apologize. This is Lindsay. Commissioner, we did actually have that $940,000 that was on your agenda probably a week or 2 ago, which was provider relief funding, and that has been posted to the COMCARE Revenue Fund, and you'll see in the quarterly report and also the monthly financial report you get later this week, that has really bailed the COMCARE fund out, as Tim talked about. The fund does have a robust balance, or it started with a robust balance, but at the end of September, the actual cash available in the account is only $1,757, and this has a total operating budget of $42.6 million. So we're definitely to crisis mode.
Okay. Thanks, Lindsay, for explaining that. Okay. Any other questions? I don't see any, Tim. Thank you very much for this update, and good luck to the COMCARE staff and yourself for leadership on that.
Thank you. Joan and her management team have done a remarkable job through all of this, and I really appreciate the work that they've done.
Okay. You're still up, Tim?
Yes.
Okay. Commissioner Howell, did you have any questions? You're on the phone before we move on.
Thank you, Mr. Chairman. I do not have any questions right now. The one slide was curious to me. It said that the county status precludes us from accessing some funds. I didn't think I heard a good explanation for that.
So mixing funds between.
Specifically, in comparison to the other community mental health centers, that the PPP loans that were available, the Payroll Protection Act loans, were not available to COMCARE or the county. They were available to the peer organizations across the state because of their nonprofit status. And so that puts Joan and her staff in a little bit different status than the other CMHCs across the state delivering similar services.
Okay, that makes sense. Well, thank you for the explanation, and that's all my questions. Appreciate you very much.
Okay. All right. Next item.
If we could switch to the other exciting part of the Division of Public Services, the Health Department. Tom described it as a brief testing update. I'll try and make it brief, but there's a lot of information, a lot of things going on around testing. Last week, the Health Department collected 1,094 samples through the drive-through sampling site, the disease containment unit, and 3 mobile outreach collections. 46% of those that were sampled were experiencing symptoms, and 54% were asymptomatic, but they met those criteria, one of the special categories. So they were frontline first responders or worked in a controlled setting like a long-term care facility or a group home or were teachers. So that's been a shift a little bit, that we're seeing more folks that are asymptomatic than symptomatic, even though we still have a number of limitations on who we can see that's asymptomatic. And I've got a point on that a little bit later as well. We collected 118 saliva samples, which were processed by CRL. Again, because of the registration process that CRL uses, average processing time for a saliva sample at our drive-through sampling site is about 10 minutes versus 2 to 3 minutes for the nasopharyngeal collection. And so we are continuing to work with CRL, especially around their registration process, so that we can get that time down so that we can shift to saliva sampling. And we intend to do that as soon as CRL is ready to change their registration process so that we can get folks through a little bit quicker. The other thing that I'd like to point out is that for anyone who's experiencing symptoms or is in one of those special categories, we are doing same-day appointments. If someone calls in the morning and we're able to get them called back by noon, we're able to get them in the afternoon. Otherwise, we can schedule them early the next day. So the delay to get appointments should be resolved. Again, same-day appointments right now if people are calling in the morning. And so I'd encourage folks, particularly if they're experiencing symptoms, to get themselves tested. In an attempt to increase the number of folks that are tested in the community, the downtown or the drive-through sampling site is going to be open on this Saturday, the 17th, for testing by appointment only. Again, we'll do 3 hours worth of testing, and we will be testing folks with symptoms or without. So this will be another opportunity to do for folks that don't have any symptoms, but they don't fit that any of those special categories. They will be given the opportunity to schedule in one of those time slots. We're going to do NP testing, sampling only that day, again, because of time. We're trying to get as many people through as we possibly can. But people can start calling 211 today, and as soon as we fill up those slots, we'll cut that off. But we'd like folks to let us know if they're interested in a Saturday sampling time. So we're experimenting on two different variables here. One's the Saturday sampling time, and the other is the asymptomatic sampling. And so hopefully we'll get some good information through that Saturday test. And then the other thing that I want to point out is that we still have 11 more mobile sites this month. And I think we've got 14 work days or 15 work days left this month, and we've got a mobile collection site on 11 of them. So health department staff have really increased the number of mobile opportunities that we're doing, and those are, if you have symptoms, if you meet those symptom criteria, there's no appointment. It's a walk-in process, and so we hope that people take advantage of that as well. The health department continues to work with Wichita State University staff as we prepare to make a transition to their lab. We're now targeting the week of the 26th to begin using WSU's lab, contingent upon them securing sampling supplies for us. Their lab process requires that we acquire our sampling supplies through them rather than using our existing supplies or finding supplies through another supplier. And so we've indicated to them what types of sampling equipment we're interested in, and they're in the process of acquiring that for us. They had planned to begin their sampling of campus athletes yesterday and begin using their lab to process that. And it also appears that they found supplies to begin a sampling project of their student population that begins today. It's unclear if those samples are going to be tested by the WSU lab or CRL. But we'll hopefully they'll learn things through that process that will speed our use of their lab along when we're able to begin using them. The WSU lab plans to offer lab services for 3 types of collected samples: NP swabs, like as we collect now, oral pharyngeal or throat swabs, and saliva samples. And the WSU process includes what they call a witnessed sample process. So someone has to be designated as a healthcare worker to either collect that NP or OP swab or observe the saliva sample. And so that's every lab has a little bit of a different approach, but that's the approach that they're taking. And so we've requested all 3 sampling supplies, and we're going to work through the process to figure out when and where and which type of sampling makes the most sense. We've had the WSU lab folks come observe our drive-through sampling site last week so that they could get a sense of how we do work, and they may have some ideas that will help us expedite things, and we'll have staff go do an observation of their lab as well in the coming days. We continue to expect WSU to get Sparks funding to help pay for lab supplies, but for right now they don't have that, and so we're working through the process to get a contract available so that we can pay them for supplies and for the lab services that they deliver. And then I also want to talk a little bit about the statewide testing initiative. There's been talk on September 28th, Governor Kelly announced a statewide unified testing, COVID-19 testing strategy. And the stated goal is to better coordinate public and private testing efforts, test approximately 2% of the state population each month, or about 60,000 samples each month. Much of the testing plan that they've described are things that are already implemented here in Sedgwick County. We've got a drive-through sampling site. The state plans to help other counties set up drive-through sampling sites if they don't have them. We've got our drive-through process set up. Much of their guidance is around testing in the schools and is dependent upon the schools being able to receive some rapid testing equipment and then collecting that. Right now, the health department's role is to do follow-up testing. If anybody tests positive with an antigen test, the state wants there to be a PCR confirmation test within 48 hours, and so we would certainly be able to help folks with that. And then we'll continue to work with the positives. Anybody that's positive, will do what we do with them in terms of giving them guidance on isolation and then doing the initial contact tracing up front. And the statewide testing plan is tied to prevalence rates in the community, and so the frequency of testing that they're asking schools to participate in, for example, is tied to prevalence. And so that's why it's really important that we continue to work to drive down the prevalence in the community through hand washing, social distancing, and wearing of masks, because that will help reduce the impact on our students and folks in schools as well. I would be happy to answer any questions about testing that you may have.
Tim, I got a question. So, this same-day appointment world, so and I think this directly relates more to students currently than other general public, but if you're asked to be in quarantine, so you're one of the 5 or 6 students around the positive case, and you go to quarantine, are they eligible to get same-day testing if they call in?
If they're a close contact, if they've been identified as close contact, and they call in the morning and we're able to get them called back before noon, we can test them that same day.
Okay.
Yeah. Now, I don't know if I can pull it up, or maybe Kate can help me pull it up. The state has issued a guidance document around quarantine and isolation and when folks should be released, and we probably ought to post this on our website as well, because there seem to be a number of questions about that. This is the KDHE direction, and so it talks about non-household contacts, and I wish that would go away, but school classmates would be considered non-household contacts, and their recommendation again is that 14-day quarantine. This is the KDHE recommendation that's related to non-household contacts. And so I know there's a number of questions about different approaches, but KDHE guidance, which is on their website, is specific to that 14 days.
Which I understand that's KDHE is doing the 14-day based on CDC saying 14-day, and so that trickles down to our health department saying 14 days.
It has so far.
I think that document would be really valuable to get on our website. Is that just a one-pager?
It's a one-page,
Can you print that just so I can?
Absolutely.
Or send it, a little link to us, because I think some of us are getting a lot of questions about this quarantine world, especially in the student world.
Absolutely. We'll be glad to send it to you, and we'll get it posted on the website today as well.
Okay, thank you. Commissioner Dennis has a question.
Thank you, Mr. Chairman. I guess my question is about that 14-day quarantine. If we can get this testing where we get WSU up and running, is there no way that we can then start testing those immediate contacts so that we can get them back in school in less than 14 days?
The current guidelines don't factor in testing. They are a time-based quarantine recommendation.
So what do we have to do in order to be able to factor in testing? Because we can't have kids out for 14 days. They come back and they get another close contact and they're out for another 14 days. That's unacceptable. We don't have any kids in school. So we've got to rely on testing in order to get them back into school. How do we turn this big ship around a little bit so that we can get kids back in school?
Well, one of the ways that we can do that is if we can drive the numbers down, and there'll be less positives in the school, so there's less close contacts. And so
But driving the numbers down, I agree that we saw what the results were from the hospital yesterday, and they were terrible. But we've got to be able to rely on testing somehow that we can get those kids back in school. So how do we drive this in order to be able to get kids back in school? This thing is perpetuating. We just bring them back. They have a close contact. We put them back out again. Surely we can test them and find out whether or not that they're contagious, find out whether they've got the virus, and we can get them back in school in less than 14 days.
The current incubation period is 14 days. The ability to infect others lasts for 14 days, and symptoms can show after up to 14 days. And so that's the science behind that 14-day quarantine. If we were in a position where we were testing every day, that's still going to lead, the tests are good for that day. And we've had conversations with Dr. Menz. I'll let Tom talk about his conversation with him recently, but right now, the best guidance that we have in terms of safety, and again, that's the health department's perspective, is public health safety. 14-day quarantine is the appropriate duration of quarantine from a health standpoint.
I had, just to support that, I had this conversation with Dr. Menz, this exact conversation, with why can't we have a dual negative test system and allow people back in to where if you were a close contact, you test on day 1, and then you test on day 3, 4, 5, or you do a secondary test, and if you get double negative, then you come back into the work environment. Why wouldn't our health department, the KDHE or CDC support that? His answer, and you look at NFL football, that's basically what they're doing. They're doing this dual test negative system to get people, the guys back into play. And I'll just give you his response. The NFL is a billion-dollar industry. They have a lot of pressure on TV. They're willing to take some risks to do that. In our world, with students, the incubation period he describes as 2 to 14 days. So if I have it and I'm sitting next to Mike and we're close contact, he can get it on day 2, or he can not manifest it till day 14, and it's a interesting virus that it has that long of incubation period, and they're trying to wrestle that. So Dr. Menz and KDHE, CDC are, they're just singularly focused on what can we do to slow virus down without taking risk and chance. And so that's how you get to 14 days. And I don't know that they'll ever change from that, Commissioner, because if you do the dual test system, and anything even short of what Tim's suggesting, an everyday test system, there's be some that will slip through the cracks. There will be some that will spread it. And in a school environment, I don't think Dr. Menz at this particular time is willing to take that chance as a physician. So that's the long and short of the dialogue I had with him on this subject, and we've been talking about it for months. If we get to a point of rapid testing, if we get to a point where we have plenty of testing capacity and it's not going to do us any good, in other words, we're going to test people and they still have to quarantine for 14 days, what's the point? And so that discussion is still ongoing. I think it's revving up because schools are back in. We're getting a better test capacity almost every day. But it is the CDC guideline at this time, which then trickles down, as the chairman said.
Okay, well, bottom line, though, in your point with NFL being a billion-dollar industry, having our kids in school is probably more than $1 billion with industry, and that's our future. So I think that's a lot more important than the NFL ever has been. Thank you, Mr. Chairman.
Okay. Commissioner Cruz?
Thank you. I wish our schools were treated as the NFL, and given the money that the NFL gets, that would be awesome. But on a side note, I have a couple other questions. So since we're on the testing and quarantine, how is the health department handling students who are sent home to quarantine yet going to work at, say, a local restaurant?
If we're made aware of that, one of the things that's available, one of the tools that's available to us that we've been very reluctant to use, but we will use if we have to, is a quarantine order issued by the health officer. And that can then lead to enforcement from the sheriff's department. I mean, we would hope that through education, we're not going to have folks do that. If someone is identified as a close contact, they are contacted. The health department staff track folks that are cases so that test positive, and then we transfer information about close contacts to KDHE because they have a phone bank, IT-based close contact monitoring system. So if you're identified as close contact, you'll hear from KDHE. They will they call you up and they tell you what it is that quarantine means, why you're in quarantine, how long you need to be in quarantine, and what quarantine means, including not going to work, not going out into the community to do things that you normally do when you're not under quarantine. And then they will follow up with them roughly every 2 to 3 days through the rest of their quarantine to check to see if they have symptoms. And then they'll ultimately release them from quarantine. So if we've got knowledge of people who are identified as close contacts, and they're not following that quarantine order, we need to know about that, and then it becomes a much more complicated process. Anybody who's a student that's identified as a close contact, they get initial contact information that says you've been identified as close contact. That means you need to quarantine for 14 days. Here's what quarantine means. So
have we sent a communication to our schools that says this is the instructions you need to give to your students? Going to work is not appropriate. We were made aware last week, a gentleman standing right at that podium made us aware last week of a student who went to work. So was that followed up on?
I assume so. If we had the individual's name, we would have followed up with him, absolutely. One of the things that we struggle with in the community is that not everyone understands what a close contact is, and so there are some folks who, for lack of a better phrase, they self-quarantine because they're a contact of a contact, for example, that sort of thing. Guidelines are pretty clear that if you're a close contact of someone who's been identified as a close contact, you don't need to quarantine. And so I think there's a misconception on both sides. I don't want to quarantine, so I'm not going to, or I'd kind of like to quarantine, so I'm going to claim to be a close contact. There's a lot of misperception. Again, this is private health information. It's not shared freely. It's possible that someone says, I don't want to go to school, so I'm going to claim that I'm a close contact, so I don't have to go to school for 2 weeks, but I do still want to go earn a check, and so I'm going to go to work. I'm not saying that's what the case was last time. I'm saying that's not out of the realm of possibilities.
Okay, thank you. And my second question is, do we have any idea, switching to testing, do we have any idea how much the WSU lab costs to set up?
We are continuing to receive invoices and information around that. We don't have a full total price yet. We think that it's around $4 million, but we haven't seen all of the backup for that yet.
So we have already provided them with a reimbursement.
Lindsay, I'll let you weigh in on this too. I believe we're going to have a contract ready. There's 2 contracts we'll do with Wichita State. One is for the reimbursement of the equipment, and the second would be for testing that Tim talked about before. Lindsay, do you want to weigh in here?
Yes. So the commission did authorize up to $1.5 million for reimbursement of equipment. We don't have a formal agreement for that reimbursement, and in fact, our consultants have been working diligently with WSU to get a comprehensive list of invoices and contracts and all of the documents that are necessary under the federal uniform guidance. So we are optimistic to be able to bring you a contract tomorrow for that reimbursement piece. It basically would leave the door open a little bit in the scope of work for us to continue that refinement, to make sure that we're not reimbursing for anything that's not got the adequate documentation for it. But likely that would include bumping up that total up to maybe a not to exceed number of $4 million, based on the information we've received to date, even though that analysis is still ongoing.
Do we have any clue how much WSU asked from the Spark task force?
Yes, so there is actually an RFP going on now, but the original proposal that I had seen in the documentation that the Spark committee itself saw was $12 million.
So the lab, please help me understand. The lab itself, we're talking is around $4 million.
I think the original plan was, that we're talking a month or so ago, that we would have this partnership between WSU, Sedgwick County, and the state of Kansas. And the theme of that and the chairman talked about this several weeks ago, would be that the county, with its CARES money, would help them acquire the equipment and stand the lab up, and the state would come in with a large-scale testing plan to upwards of $12 million worth of testing, which was several 100,000 tests. So that was kind of the premise we were working under. So to answer your question, we're looking at roughly $4 million of reimbursement to them for equipment and some stand-up cost. We will also then acquire, as Tim mentioned, some testing capacity through them, and then hope that the state comes in with the massive testing load, which would then give us the ability to test school kids more frequently and teachers and do more asymptomatic testing, which everybody wants to do in the community. That's kind of where we're at today.
So is there anything, we get past COVID, they have this lab. Will this lab generate revenue in the future?
Well, I know Wichita State's working on a business model there to, and I think without them on the phone, it's tough here, but we're trying to get things stood up and get increased testing between now and the end of the year and use as much CARES and Spark money as we can to do that. After the first of the year, if there's no other financial stimulus coming from the government regarding testing, they have to have a business model in place that they can provide testing, but then charge insurance for it and charge customers for it as any other lab would do. And I think we all understand, and I've heard Andy from WSU say this too, we know we're going to be in the testing business for all of 21. Even with vaccines and other things that are moving forward, we know that we will have to wrestle with this all through 21. And then past that would probably be a question for Andy Schlapp on what their business model is going to be moving forward, on what they're going to do with that lab.
So the $12 million from the state is for like testing equipment or the test itself?
The test itself, the commodity, the ability to run the tests. And Tim or Lindsay can correct me if I'm wrong on this, and our portion was going to be the stand-up of the lab, the equipment, the actual invoices where they were acquiring equipment, and some personnel costs. I don't know, Lindsay, is that true? Were we going to pay some of the personnel costs too or not?
That's one of the things that WIT is reviewing for eligibility, and I think they're still looking for the documentation on what precisely those personnel costs would be.
So is there a possibility to receive all of this information on a spreadsheet laid out as far as how much equipment costs, how much money is being refunded by Sedgwick County CARES funds? What are the costs of the tests? How much is it per test? I've heard a couple of different numbers. The first number was way lower than the second number. So I'd just like to understand fully, the scope of this project so that we can all be as transparent as possible with a state institution and state funds and county funds.
That's a very legitimate request. Lindsay, I'll let you weigh in. That is what we're working through, as Tim and Lindsay have both mentioned. We're having weekly meetings. Those are the numbers, and that's the landscape that we're trying to work toward as we move forward. But that's an absolutely legitimate request. It's been our goal all along to be very transparent about this, and I think it's Wichita State's goal, too, to be transparent. So.
Awesome. Thank you.
All right, Commissioner Dennis.
Thank you, Mr. Chairman. Well, how does this then play in with the 2 machines that we ordered for Sedgwick County? When are those going to be online? How many tests are we going to be able to do a day with those? What is the partnership or the integration of that with WSU? I don't know how that all falls in.
Those are good questions. So right now, we have an analyzer, a device in our lab that we use to analyze a number of different tests, many of them related to sexually transmitted diseases, but that's typical public health work that we've done for years and years and years. The 2 machines that we have ordered that should be here right after the first of the year, which is a delay. We thought that they would be here before the end of the year, but now we've received information about a delay. We'll replace the equipment that we have and we'll increase our capacity, and it provides some additional testing capacity. We would be able to process our own flu samples. We'll be able to process our own COVID samples. So at some point in time, it may be less expensive. We'll be able to process roughly 500 samples a day. And so if we're able to do that internally, that's going to be the lowest cost opportunity for us to sample. If there's no CARES money, that's by far the best opportunity for us to process COVID-19 samples. If we're in a situation where we've got 1,000 samples collected in a day and we can process 500 of them, the WSU lab would be an alternative that would be in town, so it would be a quick turnaround as well. And from the costs that I've seen, and we don't have finalized costs yet with WSU, the lab costs that we've seen from them are lower than what we're spending with other commercial labs right now, because the samples that we collect now, we send out to either the state lab, and those are processed at no charge, but they're only processing folks that meet that symptomatic criteria. And then for other folks, we are sending them to commercial labs, and we're paying for those at a rate that's higher than what WSU has indicated, but not yet finalized. And so that's WSU becomes additional capacity once we receive our devices. Until we receive our devices, they will be an alternative here in town that is relatively low cost and readily available and quick turnaround.
Okay, so right now we're using the Lenexa group. How much do they charge per test in Lenexa?
Off the top of my head, I believe those samples are $90.
Okay, and how much is WSU going to charge us per test?
Again, not finalized, but off the top of my head, I think they're at $50.
Okay, but come January, we're going to be able to do them at what cost if we do them ourselves?
Well, then we're talking about probably $10, $20, somewhere in that range. The sampling equipment or the sampling supplies and then the lab supplies should get that cost down pretty low.
Okay, well, I just want to make sure our investment in WSU is the best investment. Thank you, Mr. Chairman.
Commissioner O'Donnell?
Thank you, Tim. Regarding the WSU model that we're looking at, other universities across the country are doing something very similar. Is that correct?
There are a number of different university-based lab models that are happening across the country.
I know Oklahoma has theirs up and running. I think it'd be beneficial. We had someone from staff just give a brief overview, just maybe even just Googling all the different state universities that are doing this to know that this model is performing very well across the country. Is that your understanding?
Yes, that's my understanding.
Right.
That university-based testing is something that's happening across the country,
Yeah.
absolutely.
And that's where I think the value for WSU comes in. Obviously, the location is much more convenient than Johnson County. The cost is going to be less, and we know the coronavirus isn't going away anytime soon, that it would be beneficial for us to have this lab standing up in Wichita. And this lab will be useful for other things down the road if there was a future coronavirus, if there was a big influenza outbreak. These machines will be able to test for other things aside from COVID-19. Is that correct?
That's correct, yeah. There'll be a commercial lab that operates like any other.
Thank you.
Okay, I don't see any other questions. Or Commissioner Howell, do you have any questions before we close?
Well, thank you, Mr. Chairman, for the opportunity to speak. No, I don't have any questions. The only thing I'd say is the antigen test seems to be available at places around Wichita. Parker City and Andover has provided a tremendous service. I know it doesn't have quite the high confidence in the test results, but it sure is a convenient test in that they can deliver results usually in just a matter of minutes. Is there any antigen tests in any of our planning here that we can bring some type of antigen opportunity to Sedgwick County?
We continue to look at expanding our testing plan to include other types of tests, and antigen is one of those tests. We have not yet figured out where that fits into our process, but we continue to look at that as an option as well.
And are any
Okay, thank you. Go ahead.
Sorry, Commissioner. I was just wondering, I know for a while that Wesley was doing some Abbott testing, antigen testing. Is there any of our local that we know of, any local partners doing antigen testing here?
There are a couple of private, the quick clinic, some of the quick clinics are doing that type of testing as well. Maybe that's what CVS uses. We're going to continue to look at whether or not that fits in somewhere. That part of the statewide testing plan that the governor announced includes testing in schools, and they've identified some schools that are pilot schools. Unfortunately, none of them here in Sedgwick County. Some of that's going to be antigen-based testing as well. Then they will follow up with at our health department for a PCR test for confirmation.
Sorry, Commissioner, go ahead.
Just thinking back to Dr. Oblaw's discussion with the commission about a month ago, she highlighted the fact that one of our goals is 2,234 tests per day. That's about 11,000 tests per week, and the solution to that seems to be it was either going to be WSU or the CRL lab at Lenexa. And I know it's been over a month, maybe closer to 2 months now since we had the discussion with Dr. Oblaw. So I'm just wondering, it seems like what is our comprehensive plan for getting closer to that number? I guess I'd like to see maybe a goal timeline of some sort of when we think we're going to get, what's our strategy to get to that number?
We'd be glad to talk more about that. One of the things that has happened is that the prevalence rate in the community, and that number is calculated based on the prevalence rate in the community, has come down, which is good. And so the number of tests that would be desired based on that formula would also be down. And so that's a good thing for the community. We're going to continue to try and increase the volume of testing that we do. For example, the frequency of the mobile testing sites going out into the community to test has increased our collection numbers, and we hope that with the availability of the WSU lab in town, we're going to work with our partners to again continue to sample. The biggest challenge going forward is not going to be lab capacity, it's going to be sampling capacity, and we'll continue to do everything that we can from a health department perspective to increase our sampling capacity. We've opened up in afternoons. We try to make the sampling process more convenient. We've got a late night, and we think that our partners will continue to sample as well. But the issue is always going to be sampling capacity, I think, once we get this lab problem solved.
Thank you. I think my final question would be this. Early in the discussion on testing, we talked about 46% of the people being tested had symptoms and 54% do not. Do we know how many of the positive tests relate to each of those two categories? In other words, we know we're around 6.5% positive rate on our 14-day rolling average, but if we were to break down and say, those are people that are asymptomatic versus asymptomatic, what were the positive rates for each of those two categories? Do we know that data?
I don't know that answer, but I know people who can get that answer, and I'll get that for you, and I'll send that out to all the commissioners.
That'd be tremendous. Thank you for the chance to speak, and appreciate your presentation.
Okay. All right. I think that'll come to close our staff meeting today. So thank you, Tim, for your help, and thank you, Commissioner Howell, for being on the phone. And we will adjourn today's meeting, and we'll see everybody tomorrow. Thank you.